Welcome everybody. So we are preparing now for C3 2020, and we have a very interesting endovascular case today that I'd like to show you. This is a very pleasant 80-year-old female. She has prior history of coronary disease, previous bypass surgery, chronic kidney disease, hypertension, and hyperlipidemia. She has had atherosclerotic peripheral arterial disease for several years and has been followed by vascular surgery in New Jersey area and has been conservatively managed for several years for PAD. Recently, in last year, her claudication symptoms in the right lower extremity has significantly gotten worse. And she sought another opinion to undergo endovascular therapy of her right lower extremity. She had a Doppler study in New Jersey which demonstrated severe femoral artery disease as well as distal common femoral artery disease. However, no imaging study besides a Doppler study was available. So I brought her here today for angiogram, and she has an extremely interesting and a complex anatomy that I'm going to show you, and then we're going to discuss whatever potential approach could be and what I'm going to do with this case. So you can see we have an access from the left side. I just injected some dye from the sheath to assess the iliac artery and the iliac bifurcation. You can see there's a calcified disease in the left common iliac artery. It's hard to see, but there's a big calcium globule. There is some external iliac artery disease on the right side. Internal iliac is totally occluded. There is moderate disease in the right common iliac, and you can see that the left internal iliac artery is also very heavily calcified, subtotally occluded, and diffusely diseased. We put a contralateral catheter up and over, and we did a injection. And you can see that her distal common femoral artery is heavily calcified. The proximal SFA is occluded, and the profunda femoris artery appears to have very heavily calcified lesion at the origin. The remainder of the SFA and a popliteal artery, to her good fortune, is patent with only mild disease. And you can see that the below knee she has a reasonable runoff vessels. So given her age, given she has a previous CABG, certainly a common femoral end arterectomy and a potential patch could be considered in this case. That would be one surgical alternative. The other alternative, of course, would be to attempt at doing endovascular therapy. So what I have done so far is that I've inserted a 7 French contralateral sheath. This is a 135 centimeter length Corsair Pro microcatheter, and that's a Confianza Pro 12 wire. Initially, I tried to use a Gaia 2, which I frequently use in peripheral procedures, but it didn't work. And this is a Confianza Pro 12. And you can see that I was able to get the Confianza Pro 12 through the SFA occlusion. Now, what my hope is today is that we treat the superficial femoral artery and a distal common femoral artery, which would then allow us an access into the profunda as well. And then we can do either a kissing type inflation, or we might even consider doing atherectomy in the profunda ostium as well. So now what I've done so far is to exchange the Confianza Pro wire for a Viper wire, and we are going to do a stepwise approach for orbital atherectomy. So I've taken a 125 solid crown, and that's where we are in the procedure. I'm going to advance now 125 solid crown, and we're going to do an atherectomy of this area. So this is 2.0 classic crown. Okay, so looks promising from the movement of the wire. Karen, come to my left. Just hold the Corsair. So Karen is just going to provide some stability to the microcatheter because there's so much back tension on the system, so that I can now advance our Confianza Pro. Okay, let's advance the Corsair now. Okay, slowly. Okay, great job. Stop there. Okay, that's good. Okay, so what I'm going to do now is I'm going to do a small injection here. Okay, so this is extremely telling what the size of this vessel reference lumen is. 1, 2, 3, 4. Here, media to media again is about a 4.0. Here it's at the most 5. We're still within the origin of the profunda. And this is the true ostium. And you can see that really the calcification is very limited to the ostium and a distal common femoral artery all the way up to here. That's an artifact. Okay, and here the vessel is good. Okay, we can stop recording. Now what I'm going to do is I'm going to actually put the same IVUS catheter in the SFA and examine the proximal SFA. So vessel is pretty small, as you can see, barely 1, 2, 3, 4, barely 5 millimeters in diameter. Similar situation to, okay, so the proximal SFA is actually not that heavily calcified. This is all fibrocalcific plaque, which should respond to PTA, and here we can see the effect of the atherectomy, and then you can see this ostial heavy calcification, and then of course the calcification in the common femoral artery in the distal segment. Okay, so what I'm going to do here is we're going to go ahead and do a shock wave angioplasty using a 5 millimeter balloon, which is the reference diameter of our SFA and a deep femoral artery, and we'll deliver treatment at the ostium of the SFA as well as and the ostium of the deep femoral artery using a shock wave device, and then we can determine what else to be done. I think the proximal long segment of SFA can be then treated with either a drug-eluting stent or just the balloon angioplasty. So once I have the shockwave system ready, I'll be with you to show you the shockwave device. So we have done both profunda ostium and SFA ostium with two 5x60 shockwave balloons. I delivered 200 pulses in the SFA, and I delivered almost 260 pulses or 270 pulses in the deep femoral artery, and this is the result we have. Now I have not treated the proximal SFA. You can see So there is great flow in the deep femoral artery now, the great flow in the SFA, and common femoral looks exceptionally good. So I'm going to do a cryo here for the SFA. So this is a 5 by 150 cryoplasty balloon. So we will leave this patient with no stent, hopefully. So in future, if we need to operate on this area, it certainly will not be difficult. Okay, we can inflate the cryo, push the green button. Thank you. So the reason why I've chosen the 5.0 cryo balloon is based on the IVUS examination of the SFA. I'm going to actually do 2 inflations here.
That'll go away in a little bit, and we're just expanding that artery with the balloon. Replace.
Yeah, please. So if you recall, we had some moderate disease in the profunda, in the adductor canal, and I'm going to take an advantage of having the cryo balloon here and go ahead and give patient a benefit of having the cryo device. Okay, we can go ahead.
Ready?
So much faster flow, as you can see, in comparison to what you were seeing earlier. Another picture of the bifurcation in the proximal SFA, and looks very acceptable. Yes, there is a small linear dissection in the proximal SFA, but I'm happy with this result. This is the best we can achieve. We'll do 1 below knee angiography here to make sure that we have not embolized anything. Inject. Okay, so very nice 2-vessel runoff. So that concludes our procedure, and I look forward to seeing you all in June at C3 2020. We have a lot of other exciting things in store for you at this year's meeting, and I hope you all can join us.